Okay, so here is my signature assignment presentation. Through here. So mine is on the implementation of barcode medication administration and the reduction of errors in the medical setting. So a little background here. We'll talk about medication errors and patient safety here. So some facts we see is medication errors, they lead to longer hospital stays, they increase the patient safety risk, and sometimes they can even cause mortality in patients um, in certain situations. And then let's go over the BCMA, or the Barcode Medication Administration tool. It is a powerful tool to reduce errors, and it is very effective in the medical settings. Um, and then we can look at some of the disadvantages of the previous manual administration. We often see distractions. So nurses are dealing with multiple patients. Oftentimes they can get distracted with one patient, forget. So this is a common thing. And then also staffing shortages. Oftentimes we see nurses calling out sick, or we just don't have enough staff, period. And then even communication errors. Nurses saying one thing uh, via voice, not using software, and one nurse forgets, or things start to happen, things move fast, etc. So my peacock question is in hospitalized patients, how does the implementation of barcode medication administration compared to non-barcode administration affect the percentage of medication errors over 4 months? Okay, so let's give a little bit more of a background here, some more um, facts. So we see that 3% of patients experience preventable medication harm in the Hodgkin study. Um, so we see that this number appears low, but if we look at all the patients being treated, 3% is quite a big portion of people that experience this, and oftentimes it is avoidable. Okay, and then we see the ICU and ED are most likely departments to experience errors. ED because it's fast. ICU, we're using a lot of high risk medications, and patients are also in critical condition. Like I mentioned, the 90% of all medical errors can be avoided, according to Ward and his study. So this is a fact, right? This is something that's avoidable. And then again, BCMA helps to relieve and assist nurses in the five rights nursing process. We often see that the stage in where the medication is actually being administered, this is where most of the medication errors will happen. And so the BCMA can help with that tremendously. And then we'll go into some literature review here. So Hawkinson did his research on the preventable errors across the healthcare setting. So he had a huge study. There was almost 300,000 patients that he reviewed, and got the number, the 3% from these studies. There's a ton of different studies. I believe there's 81 different studies he did. And then we look at Alufi. He did his research on the impacts of the barcode administration on patient safety. So very similar to the Hawkinson study. And then we have the attitudes and problems with BCMA in the ED. This was done by Lunt and her team. And this looked at specifically into the emergency department and how nurses liked, disliked um, certain certain types of BCMA. And we'll go into that more throughout the presentation. Okay, so the implementation of BCMA in settings such as the ICU and OR was done by Harvard Ward. I got a lot of good research from this, and this is where he concluded that 90% of the errors done in the OR are preventable. And if it's in the OR, it's preventable. I believe it can be prevented, and up to that number more in all departments. And then lastly, Grayley and her team, they did a study on the barriers and the facilitators with the BCMA systems. And again, we'll go into that more throughout the presentation. All right, so my SMART goal here, my aim is to implement barcode and medication administration into the ED to reduce the rate of medical errors by 40% within 3 months. And the big thing on this is to properly train staff. I believe through my research and from what I've understood, that one of the hardest parts is actually just getting the BCMA into the workflow of the department, into the ED especially, because it is a high, fast paced department. And then again, we'll focus also on data collection. All right, so the methodology I will use for my project is the Iowa model of evidence-based practice. I show a little chart here um, of the entire process of the Iowa model. But two things I want to point out that I believe are the most important is we can see real-time application. So we're able to monitor, watch how the system is working in real time, which is very important. And then another beautiful thing about the Iowa model is that we can look at the specific problems that are, causing problems with the system, and we can target them. And like I mentioned, the importance of implementation. This is a huge issue, and some of the issues within the scope of it is scanning failures and software malfunctions. All right, so my intervention here will be into the emergency department. We see that previous research shows implementation can be very difficult. What we'll focus on. So main thing I believe is the staff training. This is really important. A lot of hands-on and education work. Again, staff integration. We want to integrate the entire staff into the software to be comfortable. And then monitoring. All right, so here's my implementation plan. It's a 16-week step-by-step plan. So for the first week, week 1 and 2, we're going to gather nursing leaders together. We want to create a team, strong team, where we can plan. We can see where we need resources. We can figure out the budget, and all of those good things, but really focus on the resource allocation. Second phase here is weeks 3 through 5, and this is the bread and butter of my projects. We want to make sure that we have very, 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 very efficient hands-on training, making sure all nurses are ready the second they step into the real-time flow. And then again, also we need to focus on education programs. And then we'll go to the third phase, week 6 through 8. And this is where we're going to begin to implement into the workflow, where we're actually going to pick part of the emergency department, preferably the lower acuity part. And we're going to then gather data from this on a small scale until we can figure out what needs to be picked out, what needs to be changed, etc. Then the fourth phase is 9 through 12. And this is where we're going to introduce the BCMA into the entire emergency department. This is where real-time observation is key. Are the nurses using it? Are they doing it correctly? And then also having IT support there, IT support 24/7, because we want to be able to fix software, hardware issues as soon as possible. We don't want any lapse in that area. Now the fifth phase, this is our last phase here, and this is really going to be where we're going to evaluate the errors before and after we implemented the BCMA. So we're going to look at the numbers, we're going to analyze the data. And then again, we're going to look at sustainability. How can we keep this long term, and how can we maintain this? Maybe we can't have IT support 24/7, so we're going to have to come up with goals to be able to maintain it to the point where it can run smoothly. And then some more barriers here. We have staff resistance. Maybe a staff member has been doing nursing for 30 years, doesn't want to change. We can hit this problem on the head by introducing data, like real-time data on how it helps patients, right? How it makes patients stay safer. Like the number one thing with nursing is should be patient safety. And then again, inadequate training, which we will hit on the head by in the second phase, and really make sure nurses know what they're doing. And again, the scanner malfunctions we can use with IT support. Okay, as I mentioned before, the direct observation. Are they used efficiently and correctly? Period. We can review charts, so we can look at the electronic health records, we can look at incidence reports, and then as well as we can look at staff surveys. Was the training effective? Do staff members feel that they can adequately use the equipment and the software? And also trouble with the software. Are they having troubles with the software? Are they not comfortable with it? All these kinds of things. And then my expected outcomes and implications. Overall, we want to improve patient safety and satisfaction. At the end of the day, that is the most important thing. We want to lower the rate of medication errors and medication harm. And then again, we also want to make the BCMA system easier to implement. This is the number one priority. This has been a problem in the past. We want nurses to trust it, and we want to have less stress for the nurses. We want them to be able to feel like they can give the medication and feel as though feel confident in giving it. Okay, so in conclusion, my evidence-based approach shows the analytical administration of the BCMA into the emergency department. We want to prevent medical errors, period. That is what we want to do. We want to keep patients safe. And then again, the BCMA, it does have the power to change patient lives, save lives, keep patients healthy, and also change hospitals, right? We want to implement this into hospitals nationwide because through research and through studies, we've seen it does work. And here are my references, and that is it. Thank you.